So everybody, welcome to Renal Week this week. We've got a couple of presenters today. So we've got Freddie, who's going to be presenting about acid and base physiology. And we've got Kathyrn Taylor, who's going to be presenting about renal replacement therapy, and Sapna is going to be doing the quiz. We're fortunate enough this week to have Dr. Bell, who is an ITU consultant and specialises in renal as well. So he's going to be kind of chairing the meeting and answering any questions and leading any discussions as well. So I'll just pass it over to Dr. Bell.
No pressure there, thanks. Yeah, so I'm one of the nephrology and intensive care consultants at Leicester General. Yeah, happy to ask questions, ask me questions at the end, really. See, sort of first time sort of doing this, so Shivani, I'm probably going to be guided by you a little bit, but do we just want to get on with the show?
Yeah.
Okay, Freddie, I guess over to you.
Perfect. So, can everyone hear me?
Yeah.
Yeah, brilliant. Good. I'm just checking.
Yeah.
So I'm going to talk about acid-base for the primary FRCA. And as part of my talk, I'm going to define what acid and bases are, talk about the dissociation constant and pH, and how they come in to form the Henderson-Hasselbalch Equation. And then I'm going to talk a bit about buffers, and then how the body maintains acid-base homeostasis as well. So it's all about the hydrogen ion. And what a hydrogen ion is it's a hydrogen atom that has lost its outer electron. So essentially what it leaves is just a proton. And that's sometimes why hydrogen ions are referred to as protons. And the definition of an acid and base, as per Bronsted and Lowery, is that an acid is defined as a proton donator, whereas a base is defined as a proton acceptor. So if we take this generic equation for an acid-base reaction, we can see that HA is donating the hydrogen ion or the proton, and so therefore is our acid, and the base B is accepting the proton, therefore becomes our base. These are terms. So this one, the one that accepts the hydrogen ion, is termed the conjugate acid, and the one that has lost the hydrogen ion is termed our conjugate base. So if we take an example which we'll use throughout this presentation, we can see that carbonic acid here is losing its hydrogen ion and giving it to water, forming the hydronium ion, and so therefore is our acid. The water is accepting the hydrogen ion, and therefore is our base. Bicarbonate becomes our conjugate base, and water becomes our conjugate acid. So what is pH? So pH is the negative logarithm to the concentration of hydrogen ions. And essentially what it is the measure of the acidity of an aqueous solution. So as we all know, is that normal body pH is 7.4, which equates to a concentration of about 40 millimoles of hydrogen ions. And we define acidemia as a pH of less than 7.35, and alkalemia as a pH of greater than 7.45. So what's important to note is that the relationship between pH and hydrogen ions is inverse. So if you increase the concentration of hydrogen ions, the pH goes down. And it's a negative logarithm scale. And so it's non-linear, which means for every reduction of pH by 1, there is an increase by 10 times in the concentration of hydrogen ions in the solution. So there's two types of acids and bases, weak and strong. So a strong acid completely dissociates in solution. So if you took some hydrogen chloride powder and put it into water, you would have 100% hydrogen ions and chloride ions. Whereas a weak acid and base, they only partially dissociate in solution. So if you took some carbonic acid powder and put that into water, you get a mixture of carbonic acid, water, bicarbonate, and hydronium ions. In the body, most substances are weak acids and weak bases. And so they're the important ones. So for weak acids and bases, it's important to know how much you've got of each other. And what the acid dissociation constant tells us the ratio of dissociated acid versus undissociated acid. So what percentage of mixture you've got. And this can be calculated by two ways. It can be calculated by dividing the rate of the forward reaction, so K1, by the rate of the reverse reaction, K2. Or it can be calculated by dividing your products over reactants. This then leads us on to pKa. So pKa is the negative log to the base 10 of the dissociation constant, so Ka. And pKa is the pH at which the forward reaction is equal to the reverse reaction, i.e. that you have 50% dissociated and 50% undissociated acid present. And this is important when it comes to buffers, and also is important in pharmacology concepts as well. So as part of the primary FRCA, I understand that you're meant to be able to derive the Henderson-Hasselbalch equation. It can seem quite complex at first glance, but once you've done it one or two times, it becomes quite straightforward. So you need to start off with the acid dissociation constant, Ka. And then you need to rearrange this equation to make the concentration of hydrogen ions your subject, which gives you this equation. And then from the previous slides, we know that pH equals minus log H plus. So if we want to find the pH, we need to add in minus log on each side of the equation, which gets us to this point. Then we need to multiply out the brackets, which takes us here. And we should be able to see that minus log Ka from our previous talk is the same as pKa. And so if we substitute in pKa, this here gives us the Henderson-Hasselbalch equation. Conventionally, it's written with a positive log, like here. And to do this, you just need to flip over the equation at the end. So the next part of my talk, I'm going to go on to talk about buffers. And the key principle that underpins how buffers work is Le Chatelier's principle. And what Le Chatelier's principle states is when a substance is added to a system already at equilibrium, the position of the equilibrium shifts to counteract that change. So what that means is if you added more, if we take this generic acid-base equation again, if you added more A minus to the system, so you increase the concentration of A minus, because the system's at equilibrium, the reaction will shift in the direction towards the left to reduce the concentration of A minus and to increase the amount of HA that you have and B plus. And this is the key concept behind buffers. So buffers oppose a change in pH by absorbing or releasing hydrogen ions when an acid or a base is added, as per the Chatelier's principle. So we go back to this equation of carbonic acid and bicarbonate, and we see that if we increase the amount of acid on the right-hand side of the equation, the system wants to counteract this change in pH, and it moves the reaction to the left-hand side. And this then reduces the pH back to the status quo, the starting point. Sometimes it won't, if there's not enough capacity in the system, the pH might still remain slightly lower. And the reverse happens if you remove acid from the system. So buffers and pKa. So the pKa of a buffer system is not only the pH at which you have 50% dissociated and undissociated acid, it's also the pH at which a buffer system is most efficient. So if we go back to the carbonic acid bicarbonate system, we can see that it's got a pK of 6.1, and on this curve it's the flat part of the curve where it's most efficient. So if we take this into in vivo, and which has a normal pH of 7.4, we can see that in this system it's predominantly bicarbonate ions, so 90% is bicarbonate ions, and only about 10% is carbonic acid ions. So what this means is there's a lot of base in this system, so it means that it's good at absorbing acids, but it's not very good at buffering bases. So there are other buffer systems in the body. So in the extracellular fluid and the plasma, I've talked about bicarbonate a lot. That's probably one of the most important ones, if not the most important one. Hemoglobin also acts as a buffer as well. So hemoglobin's got a histidine residue on it, which can act as the buffer for acids. And because of the Haldane effect, deoxyhemoglobin is a better buffer than oxyhemoglobin. Intracellular, there's different buffers. So phosphate is an important buffer intracellular, and also intracellular proteins. So proteins are made up of amino acids, and amino acids have side chains, amines and carboxylic side chains, which can buffer acids and alkalis respectively. So how does the body regulate pH? So we've talked about buffering, and this happens immediately. The other systems are the respiratory regulation of pH, renal regulation, and also ammoniagenesis. And I'll talk about those three briefly too. So, respiratory regulation. So, when there's a metabolic acidosis, this is sensed by the carotid bodies, which stimulates the respiratory center and the medulla. And this increases the alveolar ventilation in proportion to the degree of acidosis. And you get an increase in tidal volume rather than an increase in rest rate. But there is a little increase in rest rate. And so this is why when you have patients who are in DKA, they have these long sighing breathings, cosmal breathing. And that's what caused it. Whereas if the body becomes acidic because of hypercapnia, this is sensed by both the peripheral and the central central chemoreceptors, because carbon dioxide can cross into the CSF, and this leads to a stimulation in the alveolar ventilation more potent than just a metabolic acidosis on its own, and leads to an increase in tidal volumes and also respiratory rates. So the kidneys are very important for excreting acid, and they're the only way the body has of excreting fixed acids, so phosphoric acid, sulfuric acid, and keto acid. And they also control the reabsorption of filtered bicarbonate. So the proximal convoluted tubule, 80% of the filtered, so almost all the bicarbonate in the blood is filtered at the glomerulus. It filters very freely, and it's reabsorbed. 80% of that's reabsorbed from the proximal convoluted tubule, and this is irrespective of plasma pH. Where the control comes in is in the distal convoluted tubules and collecting ducts, and this is done by the integrated cells and the principal cells. Under normal conditions, nearly all the bicarbonate is reabsorbed. But if the body is alkalotic, less bicarbonate is reabsorbed, more bicarbonate is excreted into the urine and makes the pH of the urine rise. So I'm just going to talk about the renal regulation of bicarbonate in the proximal convoluted tubule. So as I said, that the bicarbonate is freely filtered through the glomerulus and ends up in the tubular lumen. So then you have the bicarbonate and the carbonic acid. Those can't cross the apical membrane at all, because they're not very lipid soluble. It uses carbonic anhydride to convert the carbonic acid to water and carbon dioxide. Carbon dioxide is lipid soluble, and this can cross the apical membrane into the proximal convoluted tubule cell. CO2 then combines with water, again catalyzed by carbonic anhydride. It can catalyze the reaction in both directions to form carbonic acid, which then dissociates into hydrogen and bicarbonate. The hydrogen is then excreted out into the tubular lumen by the sodium hydrogen countertransporter, and the bicarbonate is then reabsorbed into the extracellular fluid by the sodium bicarbonate co-transporter. The sodium hydrogen countertransporter works by secondary ATP transport. So the basolateral sodium potassium ATPase maintains a low concentration of sodium within the proximal convoluted tubule cell, and so therefore sodium can diffuse across the apical membrane, and as it diffuses across, that provides the energy to excrete the hydrogen ion. The last one that I'm going to talk about very briefly is ammoniagenesis. So in response to acidosis, the liver shifts from turning ammonia ions and bicarbonate ions into urea to produce glutamine. And then the glutamine is transported in the blood from the liver to the kidneys, and this allows for one extra hydrogen ion to be filtered from the kidneys in exchange for each glutamine molecule formed. So in summary, I hope I've talked and defined acid and bases and talked about pH dissociation constants and how they link into the Henderson-Hasselbalch equation. And I've given you an overview of buses and how the body maintains acid-base homeostasis. Any questions?
So everyone can write their questions in the chat function on the side if you have anything for Freddie or Dr. Bell. Thanks so much for that, Freddie. Really good.
No problem.
Yeah, cheers for that, Freddie. It was good. Yeah, does anybody have any questions that you want to put either of us on the spot on, really?
Okay, well, if we don't have any questions, we can probably move on to the. Oh wait, we've got some chat. Got some chat. No questions. You're off the hook, Freddie.
Good.
If anyone does have any questions, kind of during any of the presentations, just put it in the chat, and we can always address it later. So next, we're going to go on to renal replacement therapy. And that's Kathyrn. So if you want to load your presentation.
Sorry, I'm just figuring out how to load my presentation. It says no files available.
So where are you looking for your presentation?
On the share screen bit.
So if you click share and then browse next to whiteboard.
Oh yeah.
And then it says browse teams and channels.
Yeah.
And then for an ACCS and then general.
Yeah.
It should be in there.
Oh yeah, it is. Thank you.
No worries. I've just moved it, so that's why it's appeared.
Hi, I'm Kathyrn. I'm one of the CT1s from the north. Thank you for letting me crash your teaching. So I'm going to talk about renal replacement therapy. Any questions, please direct them to Dr. Bell and not me. So if you could just write down the answer to these, I'm literally going to give you 30 seconds because we're going to do a whole section on questions. But this is just like a little question to get you going. And then hopefully by the end we'll be able to answer all these easily. Okay, so I'm going to talk about the uses of renal replacement therapy, the principles that are behind each type of renal replacement therapy that we use in crit care, membranes that are used in it, anticoagulation, and what choices we have and when we might make them, and then just very briefly on some of the pharmacological considerations that we've got to think of when somebody is on renal replacement therapy. It's quite important because approximately about 5% of people will require RRT when they come to ITU, and we've been seeing it quite a bit, at least in Queen's with COVID. So we can use it to remove solutes and water, we can correct electrolyte abnormalities, we can correct pH, and we can remove toxins. So normally, when we remove when we use it in crit care, we use it with somebody who's got an AKI, and then either one of the following conditions. Normally, if they've got fluid overload that's not responding to diuretics, if they're hyperkalemic, if they're severely acidotic, we could use it. If they've got a rapidly climbing urea or creatinine, or if they're symptomatic with uremia, so things like encephalopathy, pericarditis, bleeding, or if they're oligureic or anureic. And the removal of toxin side, normally RRT is used to remove drugs that are more water soluble and not protein bound. So these can include sort of salicylates, barbiturates, metformin. There are some studies looking into whether or not you can use hemofiltration in sepsis to remove inflammatory mediators, but that's not fully developed yet. So I won't really talk about that other than just to let you know it's there. So there's different types of renal replacement. So peritoneal dialysis, we don't tend to use this on critical care. It's more used as an outpatient setting, and it's used by injecting the dialysate into the peritoneal cavity, and then your peritoneum will act as the membrane that we simulate in intermittent and continuous dialysis. Intermittent dialysis tends to be used in chronic renal failure in outpatient settings, tend to be given over a couple of hours, a few times a week or once a week, either via an AV fistula or a TIM. And then continuous therapy is what we tend to use in ITU settings. That uses either the patient's own blood pressure or a pump as well to help circulate the blood around the machine. And it tends to be more cardiovascularly stable because you're doing less extreme shifts in fluid compared to intermittent. So the first principle to think about is the diffusion. So diffusion is movement from a high concentration to a low concentration down the concentration gradient. And when solutes move like this, especially across a membrane, it's known as dialysis. So in the middle, we've got the semi-permeable membrane, which we will talk about a bit later. And then you have on one side the blood flow, where you have the high concentration area. And then on the other side, you have the dialysate, which you choose the makeup of it depending on what you're wanting to remove or put into the blood, for example. They're put in a countercurrent formation to simulate sort of the anatomy of the renal vasa recta and the loop of Henle, and that ensures that you've still got the difference in concentration gradient each way. The rate of diffusion is proportional to the concentration on each side, and that's via Fick's law of diffusion, and also involves sort of the membrane thickness and the surface area as well. Big molecules that are dissolved in the blood tend to go across slower because of the movement. I think it's called Brownian motion. Therefore, even though the pores in the membrane are big enough, sometimes the big molecules don't go through as efficiently. And this tends to be used in molecules that tend to be sort of less than 500 Daltons. So this is better for smaller molecules. The second principle is convection. So this is filtration due to a high hydrostatic pressure gradient. So on one side you have the blood, which is got a high hydrostatic pressure, and then on the other side you form an ultrafiltrate. So there's nothing in traditional hemofiltration, there's not actually a dialysate on the other side. You form a super kind of ultrafiltrate on the other side. So the the molecules are dragged across the membrane via solvent drag because of the blood and the water being kind of pushed against it. That does kind of get rid of all your molecules that are below, I think, 50,000 Daltons. So you tend to have to replace them either pre or post dilutional with an add-in. And depending on what you want to achieve is when you put it pre or post dilutional. So if you put it pre-dilutional, it's less likely to clog up your filter because you put in the anticoagulation at that point. But it's less efficient because obviously things that you're putting in at that point are solvent dragged across to the ultrafiltrate. There is continuous hemodiafiltration that can be used, which is a mix of both of these options. So instead of, you also have a dialysate on the other side, but you also still use the hydrostatic pressure gradient. So a little bit about the membranes. So they can either be synthetic or natural, and they tend to all have the following properties. So biocompatibility. So the synthetic materials tend to be, I can't really say it, polysulfone and polyacrylonitrile, and the natural ones tend to be made of cellulose. So the natural one actually involves more cytokine action and release than the synthetic ones. So the natural ones are less biocompatible, which in my head is the opposite way around, but I don't know if that's just me. And then the flux of a membrane is how permeable the membrane is. So if it's a high flux membrane, it's quite permeable, it's more permeable as it's hydrophobic. So they have bigger pores and they allow more water through it. The absorption of a membrane is if things have the ability to adhere to the surfaces. So if it's highly absorptive, mid-sized particles can actually get stuck on the membrane instead of going through. Thickness obviously kind of goes back to Fick's law of diffusion, as does surface area, and sort of the thinner, more larger surface area membranes are better for diffusion. So anticoagulation, as we kind of alluded to before, because you've got something, your blood is again something that's not normal, you activate the clotting cascade, and therefore you have to anticoagulate either the patient or the filter. Otherwise you get clogging of the filter and machine failure. So the first thing you do is simple things, so make sure there's no kinking in the tubes, ensure that blood flow is adequate, so we aim for about more than 100 mils per hour blood flow, and that helps prevent stasis of the blood. And then if you choose to systemically anticoagulate, you have the risks of sort of increased risk of bleeding and the risk of using sort of unfractioned heparin that go along with that. Unfractioned heparin is the most commonly used thing that we use in the UK for anticoagulation, but some places use citrate, because that's quite easy. They can put that in and then you just add calcium ions afterwards, and the citrate chelates the calcium ions to prevent coagulation. So this is just a quick look at sort of what you want to be removed, the size of the molecules, and some examples and what you choose. So if you're wanting to get rid of small molecules, so urea, creatinine, potassium, you can either choose dialysis or filtration, but dialysis is a bit more efficient. Middle molecules like larger drugs tend to be removed better with filtration, as does kind of low molecular weight proteins like cytokines, complements, things that are bigger. And then water is removed better with filtration because of the hydrostatic pressure difference. So just a bit on pharmacological considerations. Drugs that are highly protein bound are only cleared by renal replacement therapy, but in small amounts, because they tend to be protected from going across the membrane by being bound. But RRT can decrease your levels of proteins, therefore your kind of amount available for protein binding decreases, so your clearance can therefore decrease as well. Size of drug, so the bigger drugs if you're on dialysis and you've got a big drug being given, then it won't be removed because if it's bigger than 500 daltons. But if you're using hemofiltration, then that's a risk that you're actually going to be removing the drug whether or not you want that. And then sort of membrane permeability and residual GFR you've got to consider when looking at what if you need to make drug adjustments. And lastly, some complications. So you have complications related to the line going in. So they're just our normal line complications. So things like sepsis, thrombosis, fistula, pneumothorax, for example, and pain if the patient's awake. And then you've got the effects of anticoagulation. So if they're on unfractioned heparin, then you've got risks of HIT or bleeding. Hemodynamic instability, so you are still getting fluid shifts, so you've got a risk of kind of hypovolemia, and obviously the blood's leaving the body and sometimes it's not warmed, so you can get hypothermia as well. There's a risk of air emboli, platelet consumption and anemia. Electrolyte imbalances, these can be made worse if you're using citrate, so you can under replace the calcium and get hypocalcemia. And also when you're putting the dialysate back in, you can not replace the right amount of potassium, and then you can get hypo or hypercalcemia. And then obviously membrane reactions, so they can cause bradykinin release, nausea or anaphylaxis, and then metabolic. So if you putting too much bicarbonate in, you get the alkalosis, and if you're not putting enough in, you get acidosis. So hopefully you can all answer this question now with no issues. I'll give you like, I don't know, a few seconds to answer it. Right, any questions? I got my information from these resources.
Is there again any questions? Put them in the chat. Thank you so much, Kathyrn, for that. That was really informative. If anyone has any questions, please put them in the chat. And Dr. Bell, is there anything you'd like to add or explain?
No, it always seems to be like a really complicated topic, renal replacement therapy and the acid-based stuff that Freddie covered. It always get the impression that you guys, the anaesthetists, seem to need to know things in far more detail than I really understand, to be honest. As in, like, I don't know why you guys need to know it in so much detail, but your exams seem to be sort of really big on knowing kind of the real kind of detail about renal replacement therapy, and it's not just in your primary and your final as well. I mean, you know, this is your opportunity, everyone. If you've got any questions, it is a really complicated subject, and please feel free to ask. I do feel like your exams focus quite on the theoretical stuff, almost a bit more than the kind of practical applications of these things. But yeah, here to answer what I can for you, really.
So Ricky, one question I always had as a trainee, but I know the answer, but I'll see if anyone else does, is why do we not use dialysis in ITU? Why do we use hemofiltration?
Well, some places do use it actually, and it's funny you should say that. We are in the process of plumbing the Glenfield Hospital to be able to offer dialysis as well as kind of your standard CVVH. So some places do use it, and certainly other places in Birmingham do it. as do some places in London as well. There's different kind of risks and benefits to both of them, really. So as Kathyrn said, kind of the outpatient kind of intermittent hemodialysis that your dialysis patient has, that's like 4 hours. It goes on for 4 hours, and that happens 3 times a week. So it's like a big shock to the system, and patients do get unstable on it. Whereas the sort of CVVH and the different modalities that we've sort of talked about there, because they're 24 hours, they're kind of a slow, gentle process, and it's sort of much better tolerated. Does that answer that?
That's the answer I had in my mind, so yes. It's just I think it's a fact we don't often talk about in the primary teaching, is what we talk about the difference, but what's the actual practical difference? And it's the cardiovascular stability, like you're saying.
That is pretty much it. It's just that cardiovascular stability that means that patients that are unstable often can't. There are kind of adjustments you make, but often can't tolerate it. So in the recent COVID epidemic, we were running out. We used citrate here in Leicester. And we were running we were about to run out of citrate, and so we were about to not be able to do any CVVH on anyone. So we actually set up doing dialysis on some of our ITU patients, like the stable ones that were just kind of weaning from the ventilator, rather than sort of save the CVVH for the really unstable ones on NORAD, high NORAD and things like that. Got Mark Studley has a question. CVVH, CVVHD, and also CVVHDF. Yeah. So, in a very much a Blue Peter style, here's one I prepared earlier. Let me see if I can share presentation. So, can you all see this picture of a filter at the top?
Yeah.
I'm going to need some yeses from people. Can people see that?
Yep.
Yep. So just kind of building on kind of the foundation of what Kathyrn said, really. I mean, this is your kind of standard dialysis filter, which looks. This is what you'd probably see on a CVVH machine or a dialysis machine, kind of attached, and that's the filtration bit. So. Question, let me get that question back up again. So what's the difference between the different types? So you've got, probably this is the first one. So CVVH, you've got this blood coming in to the filter and being pushed against this membrane. As that membrane goes through by convection, the water that comes through will obviously carry these molecules with it, and that's kind of the simplest kind of way. That's ultrafiltration, but that'll clear some of those molecules just by pushing that water through. So CVVH is that, but then you add in some extra fluid to it, either before the filter, again as Kathyrn said, to kind of pre-dilute it to stop the filter clotting, or giving some fluid with the right sort of electrolyte content after the filter. So that is sort of CVVH. And then all of them just kind of build on that, really. So this is your CVV hemodialysis, which has a filter, but the difference being that this one's got a diacylate that goes sort of in past the filter. And that's CVVHD. And then you've kind of got a combo of the two, CVVHDF. So you've got the first one with the fluid pushing through, you've got some convection, you've got some electrolyte and kind of middle molecule, small molecule clearance. But then you've got the added dialysis with it that goes into the filter and against it. So you've got stuff not only getting cleared by convection as it's pushed through, you've also got stuff being cleared by diffusion, by the dialysis aspect of it, and that's CVVHDF. Is that okay? Maybe that explains it a bit better. It is a really complicated concept, and honestly I don't know why they kind of focus on it, but really it is kind of this kind of evolution of, let's start with ultrafiltration, let's give some fluid back, let's add in dialysis to it, and then you end up with where we are now, kind of this CVV HDF sort of picture. Right. Okay. Is that, hopefully that's explained it a little bit. Mark, first of all, Mark, is that hopefully helped a little bit? It is really complicated, and it's I think it's unnecessarily complicated. Is there anything else you wanted to ask about that? Because in the practical aspect, if I'm honest with you, you just say, can you put them on the filter, and then the nurse, you come back half an hour later and the nurse has put them on the filter, and I'm honest with you, it probably does matter in certain circumstances, but not very often, to be honest. Rikesh, as I say, in terms of when do you choose which one to use, so between those CVVH, CVHD, CVVHDF, it's whatever you've got available. I've not seen any kind of major data showing anyone's better than the other. I think it's probably more important that you know the difference between kind of the intermittent hemodialysis and continuous renal replacement therapies, but realistically they're all pretty similar actually, and it's whatever your unit has available. Any other questions?
I think from a sort of pragmatic exam point of view for you guys, that as Ricky says, it is a complex area that we go into quite a lot of the details. I like it's basic science sort of stuff at the beginning. A lot of the time you'll probably get the odd MCQ question on it, but they'll all be very similar sort of stuff. So you don't need to worry about the huge details too much, just basic knowledge of the difference between them and be able to talk about those in a potential Viva station. I've not heard of one of those for a long while, but it is something that can come up.
Just to add to that, I think probably the thing that people talk about, certainly in the ITU exams, was always, what's the difference between kind of diffusion and convection in terms of CVVH, and that seems to be the big question they ask. Again, from a practical perspective, it's not something I really think about very often, but that does seem to be something they ask about. Any other questions?
If there aren't any more questions, we can move on to the MCQ bit. This usually causes a lot of discussion as well with answers. So Sapna has prepared a couple of MCQs for us. So Sapna, if you're ready.
Yeah, just share my screen.
And last time I found it was quite useful if people post the answers in the chat, and then we can kind of discuss it afterwards.
So I've gone to share and then I click on the window. Was it? I haven't done this before.
Share and then where it says browse. Next to whiteboard, it says PowerPoint, browse, whiteboard.
For some reason it's doesn't have that option for me, which is a bit strange. I can share but that shares the whole screen, I think.
There you go, that worked.
Can everyone see the presentation or not really? Doesn't look like it.
Yeah, we can see it.
Oh, you can?
Most of it. Looks like it's cut off on the right. I don't know whether you want to go to presentation mode.
Yeah. Yeah. Can everyone see that a bit better?
It still looks like it's still not in presentation mode from what I can see.
Oh.
If you know your little
Sorry,
break,
guys.
Sorry, give me 1 second, hang on.
Ah, there we go.
On the little grey bar that's in the middle of the screen with all the buttons, do you have a request control button?
It says tape control. So I click on that to
Yes, if you click
the
that,
slides.
you can
Yeah.
control my tape. There you go.
Okay. All right. Sorry, guys. Hi, I'm Sapna. I'm one of the CT1s and in anaesthetics, and I've just got a quick quiz here on some renal physiology. I got some of these questions from primary FRCA books, so they're a combination of true false questions and then some single best answer ones. So the first couple are just on anatomy, because they come up quite frequently, as I've found in some of the books, and just some basic physiology. So the first question is on renal blood flow. So what is the normal renal blood flow to different parts of the kidney? These are all true false. So renal cortex, 500 mils per minute per 100 grams. B, outer medulla, 100 mils per min per 100 grams. C, inner medulla, 20 mils per min per 100 grams. And then the overall rate, is it between 1,000 to 1,250 mils per minute? So they're all true false. I don't know whether people want to write the answers in the chat bit or just write it on a piece of paper.
I think last time, if we all wrote it in the chat, when a couple of people replied, then we can go through the answer, give some accountability, forces us to make a decision.
Here we've got 2 people's answers. A few more seconds. Okay, I think a lot of people have answered, all quite different responses. So the answer is that they're actually all true. So the kidneys receive about 20 to 25% of cardiac output, which is the overall rate of flow, which is D, so which is true. Each kidney, so the kidney receives sort of about 6 times that of the brain per weight, and also 5 times that amount of the heart. So it's sort of one of the organs that receives the most amount of flow. A lot of this is needed in order to produce a large amounts of filtrate, and that's why it's about 10 times more overall than what's needed compared to all the other organs. But in some of the MCQs questions I've come across, they sort of want you to know how much flow goes to each part of the kidney, and all of those are true. So that's the correct answer. Okay, so a bit on anatomy. Question 2, this is another true and false question. The normal adult kidneys are, A, do they lie at the level of T12 to L2 within the peritoneum? B, are they approximately 9 centimeters long? C, do they have an outer cortex and an inner medulla? And D, is the left kidney, does it have a longer renal artery than the right? got some answers here. Okay, so I'll go to the answer and explanation. So just one of them was true this time. It's sort of a bit semantics really, but the primary likes detail on knowing the exact level of where the kidneys are. So the kidneys are situated at the level of T12 to L3. They're retroperitoneal organs and they measure 12 centimeters each, so that's why B is false as well. I've got a bit of a diagram here on the side just showing how that the right side is higher up than the left. Each kidney's got two regions, the cortex and the medulla, so C is true, and the abdominal aorta is slightly left to the midline, whilst the IVC is slightly to the right. So therefore, the left kidney has got a shorter renal artery, but a longer renal vein, which is not demonstrated on this diagram, but it just shows you how they're sort of differing in position in the peritoneum. Okay, so the third question, another true-false, is about the glomerular filtration rate. So GFR is does it occur at a rate of about 125 mils per minute? And this is in normal, like a normal healthy person. B, is it mainly controlled by capillary endothelium? C, does it result in a filtrate with the same osmolality as plasma? And D, does it favor the filtration of negatively charged or like positively charged molecules? More unanimous on this one. So there you go. So the answer to this is A, is true. GFR does occur in a healthy adult at about a rate of 125 mils per minute. And there's a small diagram at the top just showing that it's controlled by the glomerular basement membrane rather than capillary endothelium, and that's the main barrier to the filtration rate. C, it results in a filtrate with the same osmolality as plasma, which is true. The glomerular basement membrane is made from connective tissue, which is negatively charged, so it opposes the filtration of negatively charged molecules such as plasma proteins. So smaller molecules like electrolytes, urea, and glucose are freely filter. So that's why the ultrafiltrate is the same osmolality as plasma, but that's why D is false, because it favors filtration of it doesn't favor the filtration of negatively, it's more the positively charged molecules. Okay, we've got one of the last true and false questions here, and this is just about the nephrons within the kidney. So regarding the nephrons, A, are there two distinct types? B, do all of them have their glomeruli in the medulla? And C, does the juxtaglomerular apparatus, is it part of the proximal or distal tubule? And D, the collecting ducts of all nephrons, do they pass through the medulla? Most people have answered. So go to the answer. So yeah, So here's sort of the diagram of the division between the cortex and the medulla here, and there are two types of nephrons, so cortical and juxtaglomerular, and cortical is about 90%, and then the other 10% are juxtaglomerular nephrons. B is false. Not all of them have, well, they don't, neither of them have their glomeruli in the medulla. They sort of are just above in the cortex, as you can see on the diagram above. C is also false, because this one sort of, I was a bit confused on this too, but the juxtaglomerular apparatus is not part of the proximal tubule. It's just where the distal tubule is in the diagram, just above the cortex. And D is true. All of the collecting ducts of nephrons pass through the medulla, because this is where sort of the opposing forces occur, and that's how urine is formed. So all of them, even though they are shorter in juxtamedullary nephrons, all of them do have their collecting ducts that go through the medulla. Now, the juxtaglomerular apparatus has got two parts to it as well. There's a macula densa, which are specialized cells in the tubule. They sense and respond to a composition of the tubular fluid, and it's usually with response to blood pressure. And the afferent arteriogranular cells, these are the ones that secrete renin as part of the renin-angiotensin pathway. Okay, so we're going to come on to some single best answer questions now. So question 5, which of the following mechanisms would be least useful to increase the GFR of a normal kidney? And the focus is on the phrase least useful. So is it A, constriction of the afferent arteriole, B, vasodilation of the afferent arteriole, C, vasoconstriction of the efferent arteriole, D, increasing plasma oncotic pressure, or E, increasing the renal blood flow? Okay. Looks like we're all quite unanimous on this one as well, which is good. So the answer is, as everyone pretty much said, is A, is constriction of the afferent arteriole. And this is mainly due to Starling's forces and filtration dynamics, which basically govern the flow across the capillary. It's to do with changes in the hydrostatic pressure gradient across the glomerulus will affect the GFR. So if we vasodilate the afferent arteriole, the GFR will increase. So that's why B is incorrect. Vasoconstriction of the efferent arteriole will also have the same effect. If you increase hydrostatic pressure in the renal tubules, such as if somebody has obstructive uropathy, this will oppose the flow of the fluid and substances out of the small capillaries and therefore reduce the GFR. So some of these questions, you have to make sure you read it when it says least, which everyone did, so that's good. So question 6, more of a clinical based question with a scenario. A 16-year-old cyclist is brought into resus following a collision. He's got a BP of 69/38 and there is bleeding in the right flank. So in hemorrhage, which of the following mechanisms is unlikely to be responsible for the release of aldosterone? Is it A, plasma potassium concentration, B, sympathetic stimulation, C, anxiety, D, hyponatremia, or E, antidiuretic hormone? got most people going for E, which is antidiuretic hormone, and one for plasma potassium. So the answer is E. It's antidiuretic hormone, which is the least likely thing to stimulate the secretion of aldosterone. Aldosterone is released from these four main things, essentially: ACTH, plasma potassium concentration. So if you're hyperkalemic, the renin-angiotensin system, which is activated by sympathetic stimulation, which can happen in times of stress, such as that situation. But it's released by angiotensin 2 specifically in the chain, and also hyponatremia, because that's got direct effects on the adrenal gland. Aldosterone in itself promotes sodium reabsorption from urine and also from salivary secretion and sweat glands. So it's in the DCT and collecting ducts. It increases the sodium reabsorption and water, and then at the expense of potassium hydrogen are excreted. In terms of antidiuretic hormone, although it will be in higher concentrations in response to stress and hemorrhage, it's not directly involved in secreting aldosterone. Even though they work in the similar pathways, it's not something that will directly affect the release of aldosterone, even though they both work in the renin-angiotensin pathway. Okay, question 7, which relates to our earlier teach on acid-base. So if we give 50 mL of strongly acidic solution, if it's accidentally given to a patient via IV, what's the body's mechanism's first way to react to deal with this? Is it A, an increase in respiratory rate, B, an increase in the renal excretion of hydrogen ions, C, does it decrease the renal excretion and increased reabsorption of bicarb, D, do extracellular buffer systems come into play, or E, extracellular and intracellular buffer systems? See, a lot of us are going for D, which is extracellular buffer, and some of us for E, in between them both. So the answer is it's E, it's extracellular and intracellular buffer systems. So initially, any acid or alkaline insult to the body is initially dealt by both buffer systems. It's then followed by the respiratory compensation and then renal compensation, which takes longer to take effect, and you can see that clinically in patients when we take blood gases. The buffers can be both intracellular and extracellular, and it includes things such as hemoglobin, and then also the phosphate and bicarb system, which was discussed a bit earlier as well. Actions of this bicarb buffer system results in an increased carbon dioxide tension in the blood, which then increases alveolar ventilation, which is why then you can get hypercap. So patients get a higher respiratory rate to expel the CO2. And then at the same time, this all happens a bit later, the kidneys secrete hydrogen ions and reabsorb more bicarbonate of phosphate to counteract the acid, if it is acid that was the insult to the body. Okay, so our last question, intravenously administered marker of plasma clearance is given to a patient. Its plasma concentration is found to be 0.5 milligrams per mil. Its urine concentration is found to be 5 milligrams per mil. What other variable would you find most useful when calculating the clearance of this marker? So we've got A, is it urine volume in mils? B, urine flow in mils per minute? C, is it the water content of blood? D, GFR? Or E, the dose of the marker administered in milligrams? Yes, we've got quite a few people saying urine flow or GFR. Those are the most common answers. So this is all to do with the renal clearance in this calculation here. The answer is B, urine flow in mils per minute. So the renal clearance of a substance is defined as the volume of plasma from which the substance is completely removed. And the equation to calculate this is clearance, which is in mils per min, which equals urine concentration of the substance times by urine flow over the concentration of the substance. So in the last question we had two of those, so we were just missing the urine flow. So it's all to do with recognizing this equation. Just some extra things. Inulin is a substance which you can't secrete. It's not secreted or reabsorbed, and that is filtered by the kidney, and that's how we tend to calculate clearance, and that's how we calculate the GFR, is by using inulin. And then another substance called para-aminohippuric acid is a substance which is filtered and secreted, and therefore using Fick's law, the clearance of this can be used to measure the renal blood flow because it's involved in both things. And so inulin is for calculating GFR, and then para-aminohippuric acid is to determine the clearance. And I've seen this question come up a few times in some of the primary MCQs I went through. And that's it. So this is where I got my questions from, some really good resources there, and just on my references. If anyone has any questions as well, feel free to type them in. Hopefully Dr. Bell can answer some of them too. Stop presentation.
Yeah, if there are any questions, then you can put them in the chat. Thanks so much, Sapna, for those questions. I think I was getting most of them wrong as well. It's fun how much you forget.
Okay, so did I when I first did them.
Yes, if there aren't any more questions, then I just want to say thank you so much, Dr. Bell, for coming in and helping us out with this and answering questions. And thank you to the presenters as well, to Freddie, Kathyrn and Sapna, for your presentations. They're all amazing, and they should be accessible on Office 365 and on the link that Dr. Marriott has shared out on SharePoint. Again, yeah, if you do think of any more questions, just you can always email and we can pass them on. And I'll send out the feedback on the group, so please fill that out. Any comments, Dr. Marriott, Dr. Bell?
No, thank you to all the presenters, and thank you to Ricky for hosting the meeting as well. Much appreciated.
Yeah, no problems. And yeah, thank you to everybody. And if there's anything that you want to ask, I'm happy to be asked via email or whatever, really.
Okay, thank you.
Cool.